Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for this cardiovascular series. Today we're diving into vasospastic angina, also known as Prinzmetals or variant angina. This is a unique type of chest pain that isn't due to atherosclerosis, but rather a temporary spasm of the coronary arteries. We'll break down the pathophysiology, clinical presentation, diagnosis, management, prevention, and key clinical pearls to help you recognize and treat this condition. Let's get started. Beginning with some basic pathophysiology, unlike stable angina, which is caused by fixed atherosclerotic plaques, vasospastic angina occurs due to a transient spasm of the coronary arteries, leading to temporary reductions in blood flow. These spasms can occur at rest and often happen in the early morning hours. Possible triggers include smoking, stimulants and vasoconstrictive drugs like cocaine, amphetamine, pseudoephedrine, oxymetazoline, and selective serotonin 5-HT1 receptor agonists, magnesium deficiency, hyperventilation, cold weather, exercise, and foodborne botulism. It's important to note that vasospastic angina can occur in patients with or without underlying coronary artery disease. Who does it affect? Vasospastic angina most commonly affects younger patients under 50 years old, and a major risk factor is smoking. It is the only established atherosclerotic cardiovascular disease risk factor that is also a major risk factor for vasospastic angina. It's also more common in women and in those with a history of other vasospastic conditions, like Raynaud's phenomenon or migraine headaches. Regarding the clinical presentation, the hallmark of vasospastic angina is chest pain at rest, often occurring between midnight and the early morning hours. The pain is usually short-lived, about 5 to 15 minutes, and relieved by nitroglycerin. The episodes may appear in clusters, and unlike stable angina, it's not usually triggered by exertion. The classic patient is a young smoker with recurrent episodes of chest discomfort that resolve spontaneously. Some patients may also experience palpitations, dizziness, dyspnea, or arrhythmias during an episode. The diagnostic criteria are the following. Number 1, nitrate responsive angina. Number 2, transient ischemic electrocardiogram changes in the absence of obvious causes for increased myocardial oxygen demand. ST segment elevation on the ECG, which resolves after the episode, is a key clue. And number 3, angiographic evidence of coronary artery spasm. This characteristically reveals normal coronary arteries without or minimal atherosclerotic burden. And a definitive diagnosis is made through provocative testing with ergonovine or acetylcholine injection to induce vasospasm. This is confirmed by triggering of chest pain, transient electrocardiogram changes, and greater than 90% narrowing or constrictor response. Now let's move on to the management. The primary goals of treatment of vasospastic angina are to reduce the frequency of symptomatic episodes and to decrease the frequency of serious complications, like a myocardial infarction, arrhythmias, and aborted cardiac arrest. Initial therapy consists of prescribing sublingual nitroglycerin as needed for angina, smoking cessation counseling, atherosclerotic cardiovascular disease risk factor modification as relevant, and calcium channel blockers to prevent coronary vasospasms. Diltiazem and amlodipine are common ones used. For patients who do not have acceptable improvement in symptoms on calcium channel blocker therapy, we add a long-acting nitrate. And one last note here is that beta blockers should be avoided in vasospastic angina because they can exacerbate coronary vasospasm by allowing unopposed alpha-1 mediated vasoconstriction. Preventing vasospastic angina involves avoiding triggers, which were the ones we mentioned at the beginning of this episode, such as smoking, cocaine, cold exposure, and excessive stress. Patients should be educated on recognizing symptoms early and carrying sublingual nitroglycerin for immediate relief. Now let's talk book med versus street med. Textbooks emphasize diagnosing vasospastic angina through provocative testing and electrocardiogram monitoring. But in real-world practice, many cases are clinical diagnoses based on symptoms, response to treatment, and transient electrocardiogram changes. It's important to rule out atherosclerotic disease, but a young, otherwise healthy patient with classic symptoms should be treated empirically with calcium channel blockers without unnecessary invasive testing. Here are a few key takeaways. Number 1. Vasospastic angina is not due to fixed plaques. It's a transient coronary spasm. Number 2. Look for ST segment elevation on electrocardiogram during an episode that resolves afterward. Number 3. Calcium channel blockers are first line to prevent vasospasm. Number 4. Beta blockers are contraindicated because they may exacerbate vasospasm. And number 5. Smoking cessation is key. Nicotine is a major trigger. All right, let's practice some questions. A 32-year-old woman presents with recurrent chest pain episodes that occur early in the morning at rest. She has a history of migraines. She does not smoke or have traditional cardiovascular risk factors. Electrocardiogram performed during an episode shows transient ST segment elevation in leads 2, 3, and AVF. The pain resolves with sublingual nitroglycerin. Which of the following is the most likely diagnosis? Is it A, unstable angina, B, ST segment elevation myocardial infarction, C, vasospastic angina, or D, non-ST segment elevation myocardial infarction? I'll give you a couple of seconds. If you chose C, vasospastic angina, you are correct. The presence of transient ST segment elevation in a patient with episodic chest pain at rest strongly suggests vasospastic angina. Question 2. A 38-year-old man presents with recurrent episodes of chest pain at rest, which are relieved by sublingual nitroglycerin. He is diagnosed with vasospastic angina. Which of the following is the most appropriate long-term management? Is it A, metoprolol, B, diltiazem, C, aspirin and clopidogrel, or D, statin therapy? If you chose B, diltiazem, you are correct. Calcium channel blockers are the first-line treatment for preventing vasospastic angina episodes. Beta blockers should be avoided as they may exacerbate coronary vasospasm. While aspirin is beneficial in atherosclerotic disease, vasospastic angina is not primarily caused by atherosclerosis, so dual antiplatelet therapy is not indicated. Great job! That wraps up our discussion on vasospastic angina. It's a unique but important condition to recognize, especially in younger patients without classic cardiovascular risk factors. Be sure to subscribe and turn on notifications so you don't miss our next episode. And as always, this is the ProPA podcast, where future pros in medicine are made. See you next time.